Thanks, Liz. I want to thank everybody for coming today. I'm Robert Worthline. I'm the director for the Office of Behavioral Health. And I wanted to thank Health Management Associates who did a lot of work to get this population and needs assessments, behavioral health needs assessment completed, and as well as to the staff at Community Behavioral Health for all their work in working with HMA to get this work done timely. And it's really important that we do have this information as we are looking to move forward with several efforts that we're making. The needs assessment met the requirements of the state's Substance Use and Mental Health Services Administration block grant. Every 5 years, we have to complete an assessment. The assessment is informing long-term strategic planning for the current and projected behavioral health needs of Coloradans. Now, you might ask, how does this fit with the governor's task force blueprint that was just completed, and as well as other efforts that are being made to improve behavioral health in the state of Colorado, but mostly the task force blueprint. This assessment is critical for us as we move forward from the blueprint. The blueprint laid out 250 recommendations that were sort of narrowed down to 3 different phases, with 3 key recommendations in the first phase, 19 in the second phase, and the remaining to be fleshed out in the third phase. This assessment will be used in conjunction with that blueprint to make sure that we're moving in the right direction, that we're targeting the right areas, and we are deciding where to put our resources. So between the needs assessment and the recently released task force blueprint, we have more information input than we ever had before to build a behavioral health system that works for and puts people first. In the task force, more than 100 providers, advocates, consumers, and community leaders joined to offer their ideas to reform the system. For the needs assessment, HMA reviewed more than 100 existing reports on the Colorado system. Some of these reports have been around for a while, some are newer, some have been previous efforts to reform the system that have sat on some shelves. And we'll talk a little bit later about how we believe that this is going to be a different than previous reports, and that we want to apply these reports to an outcome. We want to achieve a better system for Coloradans. HMA also surveyed the community, county governments, behavioral health providers, pediatric family medicine providers, and conducted stakeholder focus groups as well. This is in addition to the listening sessions and the community conversations that occurred during the task force efforts. So we're hitting the ground running on implementation of the blueprint, and the needs assessment comes at the perfect time, as I mentioned. And at the end of the day, we want to achieve a good quality reform on the behavioral health system, and we need robust data and analysis to drive our efforts to build a system that's accessible, affordable, and equitable for all Coloradans. The needs assessment also reviews the behavioral health demand in Colorado. It assesses strengths and weaknesses of our current system, and we have many strengths, but we also have many weaknesses. It will break down these specific needs and considerations for Coloradans across the state. It's a lot of information to sort through. We know that. We're not going to be able to get to all of it today. What you'll hear today are some of the top findings. I do encourage you to go onto our website and read the full needs assessment. Probably need to give yourself a few hours. It's a pretty long document. And we want today's town hall to be an open conversation. As Liz mentioned, you'll have an opportunity to ask questions so that we can respond to those questions by the panelists. You'll have really smart panelists today, and they'll be able to give you and hopefully answer all the questions that you have. Feel free to tell us what surprises you, what concerns you, what gives you hope for the future as well. I don't want it to be all negative. I want us to highlight the things that are working and what we're hopeful for as well. We need your input to help us make key decisions on the future of the behavioral health system. And this is just step one. We have a while to go, and we will continue to engage our friends and our partners and our stakeholders and advocates and families, consumers, people with lived experience as we go forward. This is just the beginning of what we hope is a really successful reform to make Colorado one of the best states for behavioral health in the country. With that, I'm excited to introduce today's panelists from HMA and OBH, and I will have them go ahead and introduce themselves. Camille.
Hi, good morning, everyone. Camille Harding, Division Director of Community Behavioral Health. I'm going to hand it off to HMA.
Thanks, Camille. This is Shannon Breitzman. I'm a principal with HMA and part of the core team that worked on the statewide needs assessment. Gina?
Hi, everyone. I'm Gina Lasky and also a principal with HMA and part of the core team. And we'll talk a little bit about the rest of our team that was really instrumental to getting the work done. And Robin?
Hi, everyone. I'm Robin Odendahl. I'm a senior associate with HMA and really led the data component, all of this, and we'll be presenting some high-level findings for you all.
Thanks, Robin. So you can see on our slide the other members of our core team. So when you see some of the maps a little bit further along in our presentation, those were created by Elizabeth Lopez. And when we talk a little bit about our stakeholder engagement, a lot of the stakeholder engagement was arranged by Alana Ketchel. So some of you will be familiar with Alana's name as she engaged some of you. And then we had some great subject matter expertise from Dr. Marcy Eads, many of you know Marcy, and then Gina Eckert from Indiana, and Dr. Lori Rainey, who many of you also know. And then we want to really give a shout out to Camille's team, and in particular, Chris Miller and Elizabeth Brooks and Stephanie Rogers, who were really just core to helping us get this needs assessment completed and advising the process and the product and just our just a dynamite group of people. So big thanks to them and their extreme patience and great feedback and input. So you're a lucky lady, Camille and Robert, lucky guy for having such a great team. So let us, without further ado, dig into the needs assessment findings. So as Robert mentioned, the needs assessment is something that happens every 5 years. It's part of the funding requirements that OBH has with regard to their SAMHSA funding. What was a little bit different this go around is that this took place during the convening of the Governor's Behavioral Health Task Force. And there were a lot of consistency in the findings with the needs assessment and with the work that the task force was doing in its community conversations. There were a lot of convenings related to the task force, as well as the community conversations that were happening related to the 1115 waiver and substance use treatment. And as Robert mentioned, our work, HMA's work, happened very much in coordination with OBH leadership, in particular Summer Gathercole and Robert, and with real intention to incorporate the needs assessment findings and be very thoughtful about making sure that it informed decision making and aligning the ideas that were coming out of the task force with regard to the future of behavioral health. And then, of course, the needs assessment took place during COVID-19 and all of the public health actions to prevent the spread of the virus. And everyone was very much aware of the impact on mental health and really the significant impact that the virus is going to have on the behavioral health system. And so, you know, the disparities that the needs assessment found and the impact of those disparities is only going to be compounded. The need is going to be compounded because of the virus. And so the strategic planning process is going to have to consider that and will consider that moving into the future. So just want to acknowledge that. HMA's approach to the needs assessment really looked at these sort of key research areas and questions. So what is the behavioral health need across the state with attention to health disparities in particular? What are the regional variations in need and gaps in the continuum of services? And not just, what are the rural and urban differences, but when you're looking at rural and frontier areas of the state, what are the differences in those rural and frontier areas? So, we know that Eastern Colorado is really different than Western rural areas of the state, and we know that some of our resort areas of the state that are rural are really different than non-resort areas of the state. So we really wanted to look at those differences as well. And then we also wanted to look at questions like, is the current design of the system effective based on need? And how does the system of care need to evolve? And then we wanted to look at what is the role of the Office of Behavioral Health in the future. So we started with looking at what is the state of the state, and looking at overarching strengths. So one thing that we found in our stakeholder engagement is stakeholders consistently refer to the positive impact of improved access to behavioral health services that was really the result of the Affordable Care Act. And the expansion of behavioral health benefits for individuals who were previously uninsured or underinsured. They really noted the increased attention to behavioral health that had happened in the state over years. So increases in funding, increased collaborations across sectors, increased genuine interest in improving the system, more local engagement. And they noted that the state had also seen an expansion of services and improvements in specific components of care. To some extent, the expansion of services was noted to be a result of county-led and funded initiatives that were developed after stakeholders had worked to identify gaps in the behavioral health continuum of services and then implemented solutions to fill those gaps. So this included integrated care, ACT, and access to care, telehealth, and then some services in non-traditional settings. So there were a lot of county and community-based efforts that had taken place, and those are noted in the needs assessment. And then the needs assessment really looked at what are some of the challenges. So some of the overarching challenges that we're going to talk about today start with looking at a history of system level challenges. So Robert pointed out that we looked at more than 100 different documents. This is just a sample of them. We started with about a 5 to 15 year look back, but really found that we could look back as long as 30 years and found that for about 30 years and over about 100 plus reports, there is some consistency in the recommendations and some consistency in the kinds of system level challenges that the state has seen and noted. And so we wanted to do, I would say, kind of a minimal root cause analysis about why those recommendations have not been implemented to date, and why there's been some consistency in this sort of system level challenges that we're seeing. And so with these decades-long efforts to kind of address these challenges, how can we make recommendations and move forward in a way that actually leads to system level change? And I think we're going to talk about some of those ideas and recommendations towards the end of the presentation. One of the big challenges that won't be a surprise to folks is we have a really fragmented system. So we have a system that's very difficult for people to navigate. Fragmentation occurs at a lot of different levels. There's a lack of communication between state departments. There are different ways of accounting for dollars. There's fragmentation between mental health and substance use, between physical health and behavioral health, between the systems that serve individuals with intellectual and developmental disabilities and behavioral health. We have a fragmentation in our data and our funding. So this, some of you may have seen, it's something that I know the Behavioral Health Task Force looked at. And really it's just a great picture, a great image to show the fragmentation in our funding streams. So these are all of the different funding streams that fund behavioral health in the state. And the different the different state agencies where these funding streams live. So you can see the complexity and the number of these different funding streams.
Hey, Shannon, it's Camille. There's a few comments that folks can't see the presentation.
Oh, uh-oh. Okay.
It looks like, Shannon, they can see it in the primary view rather than this, or they want to see it in the primary view rather than the speaker view. I can see it in the primary view.
So some are seeing it in the speaker view and some are seeing it in the primary view.
Yeah.
Uh-oh. Okay, let me try to share again. Sorry about that. Okay, hold on one second. Share. Okay, let's see if folks can put in the comment whether or not they're able to see it in the primary view.
It looks like people can see it. I think that there might be some folks that might need to change their view. So I would say keep going.
Okay,
Yep, they can see it.
sorry about that, everybody.
Real quick for those in your view options, if you look on the top, there is view options. You can click side by side. That might help. But I also want to make sure that we are able to see the ASL interpreter as well. Sorry.
Thank you, guys. All right, I'll keep going along, and if folks in the chat, if anybody can help people with the view thing, I'm not a good Zoom TA person to help you figure out the view thing. All right, so we'll keep moving along here. The other thing that was noted in terms of challenges is really a shared vision for behavioral health for the state. And that lack of vision is a vision, again, that's shared across state agencies and across stakeholders. And you can see here kind of what that lack of vision has led to. We've seen the model, that picture around the fragmented funding, what it does around the ability to prioritize a system of care for the state, building out a continuum of care, what it does around accountability for behavioral health for the state, and what it does in terms of data and how we use data. And then again, this won't be a surprise for many of you. There are a lot of challenges around our behavioral health workforce, particularly in our rural and frontier areas, and some pretty significant gaps in training, particularly related to having culturally relevant services and care, and providers who really match the communities that they're serving. And then noted many times was the administrative burden that exists in the state and what that administrative burden leads to. So it's really impacting the ability to retain a good workforce. It's impacting the ability to get people the care that they need in a it really stymies partner collaboration. So administrative burden was certainly a challenge that we heard throughout the process. And then one of the key questions, as we showed you, was looking at particular populations in need. And so priority populations, we looked at a number of priority populations. I'm going to show you those here in a minute. Each priority population that we looked at, we created a document that does a deeper dive for those priority populations, but we did find themes across all of the priority populations, and those themes are noted here. So a lack of training of the workforce with regard to priority populations was noted. Anytime an individual had multiple identities of priority status, it was found that created more barriers to accessing services or to the quality of services that they were able to receive. So for example, if an individual was experiencing homelessness and they had a criminal justice background, or if a person had an intellectual or developmental disability and had tribal status. So the more more sort of intersections in identity, the more challenges there were with regard to accessing the care they needed. And then the lack of representation within the provider network. So just simply not enough providers of color, for example, oftentimes not enough providers from local communities, not enough providers with an understanding of the population. And so it's more related to the workforce gaps there. And then oftentimes there was just, it was felt that there was a lack of attention to the particular crisis that was relevant in a particular community. So one example of that was methamphetamine being the crisis. There's a lot of attention right now on the opioid crisis, but in some communities, it's actually right now methamphetamines that is felt to be a more significant crisis. Heightened rates of schizophrenia, particularly in tribes, and then high rates of suicide and substance use. And then we heard many times over this need for more flexible and creative funding for communities to use so that they could meet their community need. And so those were themes across the priority populations. And then here are the priority populations that we did do a deeper dive on. Now, one question that we often get is why these populations? And really there are a lot of populations that we could have looked at. So this is not every population that needs to be looked at, certainly. Why these? We looked at these because in that document review that we did, these were the populations that came up over and over as either not having particular programs or services that were addressing their unique needs, and or in the data, they were showing up as really having disparities or gaps or lacking programs or services that were meeting their needs. So, so that is why these populations we did a deeper dive on. So again, there are other populations that this doesn't mean that there aren't other populations that have needs. It just means that these really stood out in previous documents and studies or in the data as experiencing particular disparities with regard to access or quality of care, or gaps in programming and services. And so on the right side of this slide, you'll see in the documents that HMA's created, this is what you'll find in those documents. And we call this out so that you can see really how you might use these resources or tools, how they might be useful to you. So we looked at data with regard to prevalence. So things like death data, so suicides, drug overdose deaths. And then we looked at the percent of the population receiving behavioral health care, the percent of behavioral health providers who serve that population, prevalence data with regard to mental illness and substance use disorders. We looked at stakeholder experiences of care and barriers to care, the continuum of care needs specific to that population. And then for these populations, we looked at ideas for meeting the need and reducing the disparity. So each of the documents specific to these populations offers up ideas for how we might address the need and the disparity. And then I think at some point in the presentation, and I know Robert mentioned it, there is a link where you can find all of the documents. There's a document called The State of the State that presents sort of an overarching picture of the strengths and challenges that I mentioned, all of the priority population documents, a main summary of the needs assessment, and I'm going to turn it over, Robin, to you to talk a little bit more about the data.
Great. Thank you, Shannon. So yeah, I will take probably not quite 20 minutes or so to present some high-level glimpses of the needs assessment findings gleaned from a multitude of really quantitative data sources that were used to either expand upon or explain or some of the qualitative findings and some of the things that Shannon just highlighted for you. And so here are a list of all the possible, so I was basically charged with looking at all the possible data sources regarding behavioral health need, provider and services and utilization, most of which are listed here. And it's really important to note that not any one data source is available to completely assess the continuum of need and services. And so the analysis considers the best data available, with each data source really representing just a small piece of the puzzle that we know as our behavioral health system. We also recognize that many of the data sources here have limitations, and we've tried to be very clear about what those limitations are throughout the report itself. Again, we use both these data sources as well as the qualitative data collected via the stakeholder engagement that took place statewide and that Shannon referenced. We attempted to find data sources that helped answer some of our study questions as they relate to different payer types. And generally, ultimately the goal was to illustrate or to create a picture of the behavioral health system and need in Colorado, and to identify to what extent there was alignment between what we heard from stakeholders and alignment with these data. And so we combined the two data types to really offer interpretation and possible explanations of what we're seeing in the quantitative data that are listed here. On the next slide, we used these data sources to illustrate sort of three aspects of the behavioral health system. It doesn't look like the slides are changing. Wait.
Good change.
Forgive me, sorry. So we use these data sources to illustrate the three aspects of the behavioral health system. So we looked at behavioral health need, behavioral health provider and service availability, and behavioral health service utilization. And here is the continuum of services as defined in the assessment, from community-based prevention and health promotion to recovery services. And regarding this continuum, we set out to dive into the available data on the continuum of services to uncover gaps in these services. and to identify what might be considered a set of core services, and together, to really develop ideas for improving this continuum as defined here and access to that continuum. So we also assess this continuum for different populations, including different populations by payer type, so indigent and Medicaid and privately insured populations, as well as the general population and safety net population. So moving to the next slide, the analysis of behavioral health need examined 4 levels of acuity from low to high unmet behavioral health need. As illustrated here in this sort of stepwise figure, the indicators were selected to examine sort of the lower acuity unmet need, which was, we used an indicator of just poor mental health days among the general population, and also prevalence of the safety net population, which research suggests has oftentimes has a higher behavioral health need than perhaps the general population. To the more extreme cases of unmet need, we looked at the rate of emergency department utilization for behavioral health, as well as the rates of death of despairs due to drug overdose and suicide. And by looking at these indicators at the community and county level, the data present a picture of the extent of behavioral health need by region and the variation that exists across the state. And this regional assessment was really important part of the work that we did. So here, for the first time in this table, we reference geographic regions 1 through 7 that we use in the assessment. The geographic regions 1 through 7 were used because this division of the state aligns with the regional accountable entities, the administrative service organizations for crisis services, as well as the managed service organizations. And we understand that the catchment areas for each of these entities are slightly different, but we had to just define some region in order to present our data, and that this is by no means a comment on the quality of the RAE, the ASO, or the MSO, or even the actions by these entities. It's merely a method we use to divide the state into regions and to discuss regional variation. So the next slide here shows just, again, we can't show you everything that we present in the assessment, but it's an example of some of the things that we have done with the data and how you can use the data that we present in the assessment. So we present data in the form of charts and maps, and to the extent possible by regions within the state. So here we show emergency department utilization for behavioral health concerns. The chart to your left clearly shows, for example, that alcohol is a leading driver of ED utilization across the state, and that there is some variation by health statistic region. So that you can see in some regions, there may be higher opioid or stimulant issues driving ED use relative to other health statistic regions. The map on the right is the percent of ED visits related to mental health and or substance use issues, and reveals again the regional variation across the state, with the darker red areas indicating greater utilization of the ED for behavioral health. And while we see certainly that there is high ED use for behavioral health in urban areas such as Mesa County or Jefferson County or Dearborn County, we also see high use of ED for behavioral health in rural and frontier regions, suggesting that simply just proximity to the emergency department, which you might have in a more urban area, is not driving the use on its own, that perhaps it's also an indication of the availability of more perhaps appropriate or lower acuity levels of care that can intervene sooner than someone having to access the emergency department for the behavioral health need in these rural and frontier regions. Moving to the next slide, here we present an example of the content that's included in the assessment. It particularly would be of interest to you if you're interested in sort of the regional aspect on these data and these issues. We took a number of key indicators on behavioral health need and provider and services network to illustrate what's happening at the regional level. And you'll note that within any one regional profile, we use other regions and the state as a benchmark to really help provide context for the reader. This one here shows the region 1. So moving on to the next slide, I mean, there's certainly a lot to say in the assessment of behavioral health need in the population and the regional disparity that exists across the state. But the key takeaway that you'll see as you review the assessment is that rural and frontier communities disproportionately struggle with poor behavioral health conditions compared to the urban areas of the state. And this is certainly not meant to be a commentary, again, about the quality of services, but instead perhaps the role that quantity perhaps plays. We find, as we'll show you later, that there are just simply fewer providers, for example, in these regions, and that this may, to some extent, be resulting in poor behavioral health outcomes that we have seen in those parts of the state. Additionally, this finding aligns with the qualitative data, which highlighted rural challenges in terms of social isolation and, again, proximity of services and the geographic barriers to those services, transportation, other significant social determinant of health factors that contribute to need in the complexity of care in these areas. So moving to the next slide, as we did with behavioral health need, we also mapped geographically the continuum of services in the provider network. So this here is one example of a map here shown to shows the distribution of Health First Colorado or Medicaid providers and service locations that are billing behavioral health service codes by county. Not all Medicaid providers bill behavioral health services. So the darker blue here represents counties with the higher number of individual providers and includes counties, as you can see, primarily along the Front Range. So Larimer County, Boulder County, Jefferson County, El Paso County. The dots indicate the location of a Health First Colorado provider billing behavioral health services. And so again, as you can see here, visually mapping these providers suggests that there are counties with no Medicaid providers billing behavioral health services, such as Phillips, Kit Carson, really down in that southwest part of the state, as well as some on the eastern side of the state. And that these rural and frontier counties, as previously noted, also disproportionately have a high percentage of that safety net population, in part defined by those on Medicaid, the high behavioral health need, and the poor outcomes. And I just want to say real quick here that, one of the limitations of our assessment was the understanding of where telehealth is taking place and the role of telehealth in perhaps filling some of these gaps we see here in this map. So moving to the next slide, to map the continuum of services, we primarily used the SAMHSA provider locator data, which offers detailed service information on different mental health and substance use disorder organization types, as well as organizations who accept different payers. So it's not just Medicaid providers, but perhaps providers who accept privately insured or self-pay. We assigned each service in that database to a part of the continuum as described here in the slide. So which set of services were considered, for example, recovery? There were 14 service types that we coded as recovery, part of this continuum. So that's just an example of how we sort of map those services to the continuum. And if you're interested in more detail on how we map these services and what the continuum looks like, that's included in what we refer to as Appendix B of this assessment. So this chart here, though, in this slide is an assessment of the continuum of services for the state on a whole, revealing, where there appears to be higher availability and diversity of services offered within each part of the continuum. So for example, if you look at the wider part of the continuum, looking at outpatient co-occurring mental health and substance use services, part of that continuum, we see a fairly robust offering of services compared to, say, the residential or recovery services on the lower end of that funnel chart. And before I go on, I just want to, of course, it's important to note that there's really no good data out there that provides an accurate picture of services in the state, and that this is a significant data gap for us as a state and something that needs to be looked at if we really want to understand to what extent the continuum exists in parts of our state. So However, we did feel that this was the SAMHSA database was the most comprehensive source available. We did attempt to enhance or attempt to make a more complete picture by also looking at OBH Ladder's database, as well as the CDPHE Health Services Directory data. Again, trying to combine all the data sources we have to try and illustrate the most complete picture we have of this continuum. And we've heard from many stakeholders that to assess services is really an assessment of workforce. So this year, we have looked at this chart as a way to illustrate workforce challenges, right? So in those regional profiles I presented earlier, we also include this continuum of services that's presented here as the state by each region. And the regional continuums can help to illustrate, where along the continuum there may be greater workforce challenges and of course service gaps by region. And lastly, we see here again this analysis being helpful in terms of understanding and providing rationale for how funding and perhaps network adequacy standards may need to look different in each region, as Shannon has mentioned, the need to really think about how we deliver services differently based on community. Moving on to the next slide. So, at a high level, where and what were the gaps in the continuum that we identified? The assessment found that some of the most needed services are, one, not part of the state's current list of core services, and two, signifies a need for focus on additional changes to the way in which services are delivered. So, for example, we found that there was a need for more community-based and co-located services rather than only providing services in a brick and mortar mental health center, for example. We heard that the middle is missing with a need for more intensive outpatient programs, especially those who, that are tailored to a specific priority population. We heard that in terms of the middle is missing, that there needs to be more transitional step down in recovery settings for people who have received the treatment, and how do you step down and in some cases re-enter community, and as well as to sustain recovery through sober and recovery living environments, needing more of those. We certainly heard that acute care access in rural communities is a gap. Stakeholders in rural and frontier communities described significant challenges with access to crisis, inpatient, acute care for high-risk behaviors, such as overdose, suicide, and withdrawal management. And related, there's a need to increase and standardize access to more complete substance use treatment across the continuum. Underlying, of course, all of these gaps in services are workforce and social determinant of health barriers and challenges that we heard and Shannon referenced. And having something available doesn't always mean it's accessible, and to those who most would benefit from those services. And then, even if services are accessible, if they're in your community, wait lists for intakes or assessments may be long due to those workforce shortages. So it's a complex issue. It's not just about having a provider in your community, but it's also about the capacity of that provider to serve those in need. So moving on to the next slide, the key takeaway here is that services may be available but not accessible, and vice versa. That workforce shortages across the state are in part driving the extent to which the provider and services network is where it needs to be in order to meet that behavioral health need. We found that rural and frontier communities, again, face significant disparity in provider availability and choice, and that funding and the stipulations of that funding or licensure or regulatory requirements are real barriers to the expansion of key parts of the continuum in communities across the state. So lastly, our last component of our assessment is looking at the utilization of behavioral health services. So the utilization of existing behavioral health services is an important element of the needs assessment to understand where and by whom services are being used and to identify where gaps in the broader continuum exist. So again, we can map all the services we want, but if people can't access them, if people aren't using them, then that's an important part to understand and to explore. So service penetration is one access measure we use to understand whether service availability and use are enough to meet the behavioral health need. The big question we all have regarding our behavioral health system, right? Is it enough? And if not, what do we need more of in order to meet the need of that community? So we primarily looked at Medicaid service penetration rates for mental health and SUD. We provided these rates with some context by looking at primary care penetration rates, as well as national estimates of penetration rates using the National Survey on Drug Use and Health, for example. In this slide, I want to highlight here the primary care penetration rates, which were used as a proxy for just general healthcare utilization. And we found that even with primary care, as a health service, which is typically, considered more available, and as a care that has fewer access barriers, such as stigma that may come with accessing mental health and substance use disorder treatment, primary care penetration rates are lowest in rural and frontier regions, 4 and 5, for example. And one hypothesis is that, in these two regions, there's just significant social determinant of health and cultural differences, perhaps in healthcare utilization, that may be impacting these penetration rates. So again, it's not, whether or not there's a service available in the community, but the complexity of being able to access that service is something we spent a lot of time in the assessment looking at. And so if you're interested in really diving more into these barriers as it relates to the different populations, those priority population compendiums that Shannon referenced earlier really help to provide descriptions of the root cause of challenges to access and utilization for for these priority populations. And Appendix A goes into greater detail on the Medicaid service penetration rates, of which some of the key findings are highlighted here on this slide. Lastly, I wanted to show one example of a map that we used and created to illustrate the complexity of behavioral health need, the provider network, and the social determinants. And so here, we had first conducted an assessment, right, of to what extent do provider locations meet the network adequacy standards. And what we found is that, the locations that we have here that are mapped here are all within those network adequacy standards. But of course, when you layer in the perhaps, social determinants such as transportation or housing, that even though you might have a location, the access is not there. So this map looks at one social determinant of transportation, looking at households with no vehicle. And what you can see here is that those dark red color indicates area of highest safety net need, as well as high percent of households with no vehicle. And so those are the areas that really are just these hotspots of, it's not just about having a location there, but it's also thinking about different ways of delivering care in those communities where there are tremendous social determinant issues. Now, this map is a statewide map. Again, in the Appendix A that HMA created, we include maps for the Denver metro area, for Mesa, for Front Range, because certainly the patterns that you see here certainly show up in the urban areas as well. And in conclusion, service penetration, and just service utilization generally is just a very difficult metric to report and to summarize for the state. There is no one collective source for services and for utilization, no one defined measure for service utilization. So really thinking about how we want to do that as a state and understand where the penetration rates are working and where they're not is a data gap that we should be looking at as a state, and really thinking about ways to deliver services in a way that improves utilization as far as we understand it. So with that, I turn it over to Gina, who will present main ideas for how we will address some of these challenges with the behavioral health system.
Thanks, Robin. Hi, everyone. This is Gina Lasky. I just want to say a couple of things before I talk about the ideas that we put forward. There's been a couple questions that we can take into the conversation, and we will for sure have time for Q&A. I will go through this piece fairly quickly. I know we're a little bit behind in terms of the timeline that we outlined. So I just want to make sure people know that we'll address questions that you've raised in the chat, which are great ones. So if you want to go to the next slide. Shannon, can you go to the next slide?
I did, but Gina, you look frozen.
Okay, so oh, can you hear me now?
We can hear you. Your face is a little bit frozen, but we can hear you.
Okay, sorry about that. So the ideas for the behavioral health system came both from our thinking, they came from stakeholders and individuals with key experience who had thoughts about how to make things differently. And then it also came from research on best practice nationally. And so the ideas are a combination of those things. The first is, of course, one that we've heard in many of the recommendations and many of the reports over 30 years, and also fits with what the Behavioral Health Task Force talked about, which is the need for a single state authority. And really that is for a couple of reasons that Shannon highlighted at the beginning. It really reduces the fragmentation of payment. It really reduces the fragmentation then that comes from that payment with regulatory requirements or administrative burden, as well as contract requirements. It puts together data and makes the integration of data and the ability to look at the system much easier. But I think one of the things that from our perspective is most important about that single state authority is that it creates a strategic and clear vision for the state about the behavioral health system. And the need for that to be able to say, here's the continuum we really want, and here's how we're going to build it by blending services, by blending resources, by blending networks. Right now we have multiple networks that are sort of disconnected, serving different populations, and that makes it exceedingly difficult for people trying to navigate the system to get the care they need. There was a comment in the chat that a lot of individuals don't understand the benefit that exists in Medicaid or in other health coverage platforms, and that's true. I would say it's still a difficult system to navigate particularly if you have more complex needs to find the service that you need across these different networks. So that single authority, I think, we started that as our starting point for ideas, and certainly a lot of our ideas stem from that. At that same system level, another really important concept is care management for behavioral health. The task force and others have talked a lot about care coordination. It comes up regularly, the importance of coordinating care, particularly for individuals with complex needs across multiple conditions, primary care, physical health conditions, behavioral health conditions, intellectual and developmental disability or other cognitive challenges. But really care management is a different level of that, and it's what we see this data as really needing. So a higher level of data looking at risk stratification, looking at highest risk populations, looking at the populations who do not come into services but are at high risk and in need of that intensive outreach and proactive outreach, and then a much more individualized assessment of need and wrapping care around those individuals. So we spoke to that quite a bit, and you'll see it a lot in the priority population. A lot of the priority populations we see needing more care management. Of course, Colorado has been a leader for integration of behavioral health and primary care, and with the SIM and other things, grassroots opportunities, we've had a lot of good integration of primary care and behavioral health. However, there's more to do to support that in the primary care setting, to address harm reduction, to improve early screening and early intervention, and to help support many of the individuals in the populations who don't have access to behavioral health services or who don't need that level of care, so that we can use our specialty services for the higher risk populations and those priority populations that are not getting their needs met. Also, the reduction of administrative burden, and we talk about this in two different ways: administrative burden for integration. So doing things like not having a psychosocial assessment or service plan required for integrated care primary care settings, where it just isn't a very good match for pace of care in primary care and isn't really appropriate for mild to moderate treatment. But also reducing administrative burden across the board and looking carefully at, and I think this is part of what the task force looked at as well, and part of what the Behavioral Health Administration, that single state authority, is going to be looking at, is how do you streamline that administrative burden to reduce it, so that providers can do more with the services, more with dollars, and also that we can have more innovation. We heard that from counties, providers, and from individuals receiving services, that they saw administrative burden as a challenge to the system. We talked about a number of different requirements or ideas, I should say, for the workforce. And one of them was to create a statewide task force to think about workforce. I think that the Behavioral Health Administration will largely serve that function, thinking carefully about a strategy for workforce. However, we also had some other specific ideas about workforce because it was so important to the regional and frontier regions where we found the highest need. So one of the things is to raise behavioral health salaries. And I will say that this is a complex issue. It is not simply raising rates. It is not simply raising what the state pays. It's also changing how organizations pay, how we think about salaries, and how we think about parity in the United States for behavioral health. So this is a big one, and it's going to require multi-sector partnership to get there. It's not a simple solution like the Medicaid or OBH just raises their rates. It's much more difficult than that, but it is something that we probably need to address to help retain and attract people to the behavioral health workforce. Robin talked a lot about data, and the data metrics are really challenging in our state as they are nationally for behavioral health. They're as fragmented as the system, and there's not always good and clear defined metrics for what we want to measure in terms of quality and change. And so there's a lot of work to do there to integrate that data, better define the data metrics, and also have more clarity about what we need to track to be sure that Coloradans are getting their behavioral health needs met, regardless of their level of need. Next slide. Okay, so a couple of other that gets down to a little bit more of a weedy level from that system level of care ideas. So expanding and tiering the behavioral health workforce, other states, particularly with rural and frontier regions, or even what they call village regions in Alaska, have really successfully used non-licensed behavioral health workforce to address need. And so we made some recommendations specifically to the model that's used in Alaska, which is called the Behavioral Health Aid, which trains community members that have cultural relevancy to the community, often look like the individuals that are seeking services. They have good understanding of geography and some of the other pieces that we know stand out for individuals who think that there are challenges with access to care, and leverages them to expand the workforce with supervision and training from the licensed staff. So that's a recommendation that would really allow us to expand workforce in those rural regions where we heard that that's part of the challenge for expanding services where there isn't adequate access, or where there are some disparities in terms of populations. Also, some creative ideas about could we work with academic institutions to better prepare the workforce. One of the challenges we hear from providers is that people they don't know what they're getting into to work in the public sector. They haven't been trained to work in the public sector. And so having a conversation between the academic institutions and providers about how to do that so that providers aren't having to do it all on their own over and over, which is a burden for them, and also probably frustrating for the individual who's moving around in their career. Investing in statewide training and technical assistance, and I think this is a role that the Office of Behavioral Health could really play, as well as part of the Behavioral Health Administration, is really expanding training and expertise on some of the things that are missing in our provider network. So things like understanding and being able to assess criminogenic risk, having a better idea of understanding and assessing aggression, which is a population that frequently is being left out of services. Criminal justice and forensic populations need a little bit more support around assessment and training. And there are also other areas that we see the need for statewide training and technical assistance, evidence-based practice, and some other elements. And so there's a long list of potential areas for training to expand services and to expand opportunity through that training. We had an idea about something called the Centers for Excellence, which would be a combination of things. So a regional center that can offer expertise in terms of training to other providers.
Oh, looks like we lost Gina. Are you there, Gina?
I'm so sorry about that, you guys. Can you hear me?
We can hear you. You're just a little bit.
Can you hear me, Shannon?
Yep. Go ahead.
Shannon, can you hear me?
We can hear you. Go ahead.
Okay. I'm so sorry, guys. It's very windy where I am today. And okay. So we also talked about an idea I'm going to turn off my camera just so that helps a little bit, for centers of excellence. And the idea here was that they would be regional centers of excellence for training, but that they could also be regional centers of expertise to offer a suite of services that are really sort of core services for the state, and then would have a different alternative payment model. So you could think of federal programs like CCBHC, Certified Behavioral Health Centers, as a model like that, but we tried to leave the payment structure out of it so that the state could be creative in thinking about how would we create regional structures that offered expertise to each region and to meeting regional need. We recommend that the state consider a broader set of core services and adapt the statute addressing core services, and that they expand the location of those core services through collaboration with non-traditional providers. We met a lot of providers who are not necessarily considered part of that core statute, but who are delivering services and could partner with the community mental health centers or other core service providers to protect, and particularly to reach some of the priority population's needs. Next slide. So on the next slide, we talk about, this is just really an example to show you that we tried to provide recommendations, as Shannon pointed out earlier, through the priority population document. So each priority population document has ideas specific to that priority population. So if you're interested in looking at ideas and recommendations, I would encourage you to make sure you look at the priority populations as well. So I won't go through all of these for the sake of time, but just to highlight some of the things that we suggest for the SMI population or individuals living with serious mental illness is having more intensive services like assertive community treatment, potentially opportunities to address more of their physical health needs like cardiovascular disease and smoking cessation, having more peer and peer-led programming across the state, again, leveraging a different part of the workforce to address needs, and to increase provider training on some specific parts of best practice for treating individuals with serious mental illness. And there are many others, I would say, in this document as well. This is just a snapshot of the recommendations specific to that. Next slide. So before I hand it off to Camille to talk about what the state will be doing with all of these recommendations, I wanted to just highlight that there are 26 documents, and that the website can be a little bit confusing of which document you should read for what. So I just want to try to offer a little bit of support to that. The main summary document is the summary that will cover a perspective of the whole assessment. So stakeholder engagement, the data that Robin talked about, as well as recommendations. It doesn't cover every data point that we looked at. So if you're really interested in the data, you might want to dive into Appendix A. If you're looking for sort of the public health data, what have previous reports found, what are some of the, a little bit deeper dive into the strengths and challenges that Shannon reviewed, that would be in the state of the state. And then we have the priority population documents that go by priority population. So those are each, and Shannon talked a little bit about what's in there. And then the regional documents, which Robin mentioned, that can help you look at things by region. So I will hand it off to Camille to talk a little bit about.
Okay, so thanks, Gina. So for next steps in planning, I just want to also recognize that we have Senate Bill 19222 that we just did some stakeholder engagement with, that specifically calls out some activities that healthcare policy and financing and the Office of Behavioral Health need to work on in partnership, which is to take the safety net definition that was created by the Behavioral Health Task Force and the Safety Net Subcommittee and work together to create some additional criteria for high intensity behavioral health services and develop a draft implementation plan. So the draft is ready, and we will be doing some monthly engagement with providers around the communities around the state to really get better criteria around high intensity behavioral health services and what we think that needs to look like regionally, with completion of a final proposal for July 2021. So many of the recommendations that are in the needs assessment, I think, are important for us to look at as it pertains to Senate Bill 19222. And a lot of the recommendations from the needs assessment are aligning really nicely with some of the work for Senate Bill 19222. So as you can see, we have a ton of data. So we are currently in the process of crosswalking the requirements from Senate Bill 19222, the Behavioral Health Task Force Blueprint, and our needs assessment, and are really trying to organize it in a way that allows us to look at populations, allows us to develop timelines, so short-term, medium-term, and long-term, and phase out the work, and then where those specific solutions and recommendations are. So some of them are systemic recommendations that we think needs to happen across the system. And then some of them are really weedy recommendations when you start looking at priority populations or geographic catchment areas that may not have the right mix of services. And then finally, in partnership with Summer and the development of the Behavioral Health Authority, I think that there's lots of opportunity for us to leverage this information as it pertains to moving the recommendations forward in the blueprint. So we have this next set of OBH priorities. So specifically, we are working to define serious mental illness. When we look at serious mental illness right now, we do not have a really concrete definition of serious mental illness, and it's really just diagnostic based. And so we are working to define serious mental illness as well as the services for individuals with serious mental illness. We think that there's a lot of opportunity to really build out that set of services and make sure that we have the right mix. In particular, I think we are interested in looking at alternative care facilities and group home type settings as a way to step individuals out of inpatient levels of care back into the community, so that we can make sure that there's some stability, further stability for those individuals. And then the other area I think that we're really trying to consider is telehealth. We have a lot of telehealth infrastructure that was stood up really quickly during COVID that we really want to make sure that we build on that infrastructure and maximize opportunities, in particular in rural areas. So some of the ways that we're thinking about that is we know that we have assertive community treatment programs around the state that serve individuals with serious mental illness, but oftentimes those are just in communities where there's enough population density. And so we're trying to really think about how do you leverage telehealth and still deliver that level of care that someone might need, and then mix in some of the in-person services in addition to the telehealth regionally, so we can make sure that we have better strategies for engaging those individuals with serious mental illness that live in rural or frontier communities. And then additionally, we know there's a lot of work to do around workforce, looking at opportunities to leverage peers, the behavioral health aid model, and other instances. And so we believe there's a lot of work to do there. And then additionally, I think we have housing and homelessness and insecure housing that we need to work really closely with the Division of Insurance on how we build out that strategy. Additionally, suicide reduction. We have a few areas in our budget requests this year. They're in the governor's budget that I think consider suicide reduction and behavioral health technology in particular. We're thinking about how do we provide our crisis system with additional support for assessment for children and adolescents to make sure that they have the skills to intervene with families, because that's different. Children and adolescent services should look different, and we want to make sure that those providers have additional training and support to be able to manage both the child and adolescent that might be in a crisis, as well as gives support to the caregiver in the right way. And then finally, just around behavioral health technology, I mentioned telehealth. We have a request that is related to building out virtual crisis services, as well as, oh, I forgot to mention on our suicide reduction, we also have additional support for individuals with disabilities, so additional training and support to make sure that providers that are intervening in a crisis are not actually escalating the crisis, that know how to intervene with an individual with disability. And so then the technology request, we also have the telehealth request for virtual telehealth crisis services, that once you have that infrastructure in place, we think there's lots of opportunities to leverage that infrastructure for telehealth technology. It includes some small grant programs for smaller providers around the state that may not have the resources to purchase a telehealth platform, but may be part of our behavioral health network. So there'll be some grant opportunities in the budget request. And then I think in particular, the provider burden recommendation, a few things there. Some of the recommendations in the behavioral health technology budget request are opportunities for us to really consolidate all these disparate data collection systems and really develop a population health approach by building out and aligning all of our technology and data reporting requirements. And then beyond that, we're actually in the process of writing a provider burden analysis so that we can understand where our rules, our contracts that impact the provider that's delivering services, and where there's lots of burden for those providers in terms of documentation standards, and how do we loosen some of those up for individuals that are in a crisis or just seeking mild to moderate intervention and don't need the whole host of things that are currently required per rule for documentation at the provider level. And then at the system level, we're also thinking about where there are opportunities for us to consolidate, align, and streamline some of that provider burden. So I think those are our short-term priorities that we are going to be looking at and really addressing in the next 6 to 9 months. And then there'll be additional sort of work that we're obviously, this is a weedy report that we have a lot of work to do. And so in combination with Senate Bill 222, the Behavioral Health Authority, and the needs assessment, I think that is, we have our work cut out for us, I would say. So with that, I think we are going to move to questions. So I'm going to kick it to Liz.
Great, thanks Camille, and thanks everyone. As a reminder, keep putting any questions either in the chat or in the question and answer box. And I know we've addressed quite a few questions along the way, so thanks for your good thoughts so far. We'll go through a few of the questions that were submitted in advance. And so the first one was kind of about the different research that is included in the needs assessment and those 100+ reports that were looked at, and kind of the recommendations in those and what causes recommendations to not be implemented. Robert, do you want to start off with some thoughts there?
Well, I'll let the others talk about what's in the background and the method by which they pulled information. But as far as we are all aware of previous reports and recommendations, and there are real challenges. And some of those reports are very high level. So there's a need there are a couple of things that are important, I think, that we're doing differently this year between this assessment of the implementation plan through Senate Bill 19222 and the Governor's Behavioral Task Force. We're assigning leads, right? We're really clear on who's taking the lead, who's responsible for it. And one of the big recommendations of the task force was creating a behavioral health administration. So there's, even among different agencies, we have a point person in the state of Colorado who's ultimately accountable for the behavioral health system and the success that we have as a system. Obviously, like everything else, resources is a question, and funding. You know, some of these recommendations are things that we can do without resources. We're making efforts today. Camille just finished a review of data collection requirements for providers. So that's a provider burden effort that we can take without additional resources that we're looking into. And then those that require resources, for those that I think almost everybody on this call knows how it works in the state, is that we have to put together a budget request. It goes to the Joint Budget Committee, then it has to be approved by the General Assembly, and it has to be done within the amount of money available for all services in the state of Colorado for all populations within the Tabor cap. So those are sort of some of the limitations that have occurred. But we're hopeful going forward with this blueprint for behavioral task force and using this information from the needs assessment. We're going to make some real changes, and we're already starting with that by moving forward with the creation of Behavioral Health Administration and having those conversations with key parties over the next 6 months. We did hire a vendor who's going to start having conversations with different funding agencies and payers to have that conversation about what that would look like. And then we'll also have stakeholder engagement process for that as well.
Great, thanks, Robert. Anyone else have anything to add? Okay. We've gotten a few different questions about the priority populations, and I know, Shannon, you went over that a bit, but just in how you picked the different priority populations and, you know, some populations that potentially weren't included. I think we've gotten questions about fetal alcohol spectrum disorders, about pregnant moms, and about the perinatal population. And I can repeat those if you need.
Yeah, I mean, I think I talked about just that we picked the priority populations based on data and based on the various reports that we reviewed and the populations that were identified as experiencing disparities, as not having programs or services that were directed towards those populations, or where there were particular gaps in services or programming. I know Gina and Robin, there are some particular places in our needs assessment reports where we talk about, I think in particular, fetal alcohol syndrome. So do you want to point those out?
Sure. So we did add fetal alcohol syndrome. We had a couple of people reach out to us early on saying, you know, they thought this was a priority population. So we added it to the provider survey, where we asked providers whether or not those individuals, we gave them different groups of individuals, different populations, and asked them how often those individuals were excluded from intake, or whether or not they had challenges to access to care. And so we added fetal alcohol syndrome to that list. Some of the breakdown of that data is in Appendix A. I think figure 21 has some data on that. And we did ask stakeholders, as people started to raise for us, you know, what about older adults, which is we assumed would be a priority population, or what about fetal alcohol syndrome? We did start to ask stakeholders as we met with them. So when we asked counties or communities or other provider groups or individuals with lived experience and communities, we would ask about those priority populations if they didn't get raised. And I'm going to turn my camera off again, just so to make sure you can still hear me. And then what we found was that often they said, no, I don't think that's a population. What I would say is that there's many, many populations who need other kinds of services, or who are priority populations, and that they have a specific challenge with behavioral health. I think that the priority populations we pulled out, we really tried to pull out populations that were clearly having health disparities, or were experiencing very consistent themes across reports, across provider groups, that they were not able to access services. I think that, in terms of Jordan's question about why don't stakeholders list some of these other groups like perinatal populations or gender responsive, I think the gender responsive we did hear a lot about, and we would include that in the LGBTQ plus priority population group. I think that the reason stakeholders often don't think about perinatal groups is that they think about the groups that they hear the most from. And obviously that's a group that doesn't necessarily have a constituency advocating for them. So I think prevention is always something that is a little bit left out of the behavioral health space. We tend to think about services and lack of services. And so I think those are probably part of the reasons. I certainly don't think the 12 populations we selected are the only populations that need attention in the state, but maybe might need different kinds of attention.
Great, thanks, Gina. Okay, another question that was submitted in advance is, why did you use the data sources you used? Robin, do you want to take that one? Is that you?
Sure. I mean, again, the big part of our initial kind of foray into this assessment was a look at all of the data that was available and really assessing them for what they can offer, but also what their limitations are. So, you know, and again, trying to use those 3 buckets, right? So organizing the data in that way. What data can speak to behavioral health need across the continuum? What data can speak to provider services and locations, and that the network that exists here in the state, and then what data are available to speak to utilization. And, you know, it's really just trying to combine them in creative ways to, again, illustrate that picture, create that puzzle, put the pieces together. So in terms of, yeah, so I mean, it was really just trying to use the best data that are available to answer the questions we had. Does that answer the question? Or Gina and Shannon, would you add anything more?
I would just add, Robin, that I think we also looked at what do other needs assessments, what have been data sources used in other needs assessments. We looked at the SAMHSA toolkit for needs assessments. We looked at other state examples. We looked at national data on how people looked at need. And then we looked at, you know, really every single data source we could find that was relevant to the questions we were asking.
Thanks, Gina and Robin. And we did get a question just sort of about, you know, makeup of the stakeholder group for the needs assessment and kind of versus the task force itself. So who were the stakeholders for the needs assessment? And then who were the sort of like 25-ish members of the task force? Robert, do you want to start out talking about the makeup of the task force? And I know you have to leave us at some point soon anyway.
Sure. So the task force, there were 27 members on the main task force, but there were over 100 members between the subcommittees and the main task force. We wanted to make sure we got some representation from across the state of Colorado. So it wasn't just Denver focused. We've heard that time and time again about committees, and so we made it an effort to get representatives from other parts of the state. We also want to make sure we had people who were themselves consumers or represented families and people with lived experience was really important. We also wanted to make sure that we had representation from providers. I mean, obviously with 27 people, we're not going to capture everybody. So we try to capture a representation in large buckets, as well as some local representation, rural representation. There was Commissioner Pelton from Logan County, to represent sort of Eastern Plains and some local representation as well. So it really was a diverse mix up, as well as the Lieutenant Governor and the cabinet members for healthcare policy and finance, CDHS, CDPHE, and as well as Commissioner Conway from Division of Insurance for the private insurance sector to represent the state on that angle as well, and Barbara Drake, who also represented counties. So we tried our best to make it as diverse and representative as possible without making the group so large that it becomes difficult to get the work done. And we only had a year to really get the work done. So it was a quick timeline to get all that work done. We did take efforts to make sure we heard from folks. We reached out to different groups, different individuals. We encouraged participation. We held listening sessions before COVID. We held listening sessions across the state. We held virtual ones as well to make sure we got as much input as possible, and did our best to really, at the end of the day, I think that what we had and the members are folks who are either professionally dealing with, personally dealing with a big majority of their job around behavioral health, and they're working the behavioral health field or experiencing the behavioral health system on a regular basis. So that was the behavioral health task force, and I do need to go, and I want to say a couple things. I do want to answer the one question here about mental health and substance use, because in the chat there is a question about silos, and at OBH we fund both of those things, and we are making an effort to go into the direction of integrating those efforts in the future, and that came up in the task force as well. A need to we're sort of creating our own silos by treating people and our funding buckets versus what they're experiencing, and mental health and substance use often overlap for individuals, but we're still treating it as two different worlds for these individuals. So we are eager to move in that direction of whole person care, but to also include that integration, because I do think that is vital. That doesn't mean providers have to be experts in both areas. It means our approach to behavioral health as a state has to be more holistic than it has been historically. So we're looking forward to that. I am confident, almost hell-bent on reforming our system and getting better. We know we got a long ways to go. We know we can't do it without consumers, providers, lived experience, families, advocates. None of us can do this on our own if we want to have a real meaningful reform. And I'm really eager to see where we can go in the coming years. So thanks, everybody. Thanks for your time. Thanks for caring enough to come and listen and ask questions. So thanks.
Thanks, Robert. And someone from the HMA team, do you want to talk a little bit more about the stakeholders for the needs assessment?
Do that. Yeah. So this is Shannon. So, what we heard, I think, really loud and clear right at the outset is that people were really burned out with being asked the question about what's wrong with behavioral health in the system in Colorado, and knew that there was an effort with regard to the behavioral health task force and with regard to the 1115 waiver and substance use treatment. And so we sort of rethought our plan around stakeholder engagement and made an effort to, instead of asking the same questions that those efforts were asking, instead to attach ourselves to those efforts and review the notes from the community conversations and attend the meetings that were happening with the 1115 waiver and substance use treatment. And then instead meet with people that hadn't been engaged in those other efforts, and go to places in the state that those other efforts hadn't gone to, or that previous efforts maybe hadn't visited. And so that was our approach. And so we traveled to places in the state that people hadn't been to for a while, and met with partners that maybe hadn't been engaged with the sort of questions that we were asking. And I can't remember the number of stakeholders that we met with. Robin, I don't know if you have that at the top of your head, but all said and done, it was a lot of people and a huge spreadsheet, and lots of questions were asked. And one of the things that we also did is we really looked at those priority populations and tried to engage community-based partners who were working really directly with those populations. Met with lots of partners working in community mental health centers, talked with partners working in emergency departments and working in the crisis system. We talked with our partners working in the counties who have really created some of their own solutions, so that was sort of our approach to the stakeholder engagement, was to plug some of those gaps that some of these other efforts hadn't addressed. Gina or Robin, I don't know if you would add anything to that.
I might just add that again, in terms of understanding all the different documents we have available, that the methodology in the sort of the main summary provides a lot of detail about our stakeholder engagement in terms of how many organizations we talk to by type, by geography, by population. We engage them through discussion, we engage them through survey. So if you'd like more detail on that, it's in that section of this masterpiece.
Love it. Masterpiece is right. Okay, so kind of along those same lines, we had gotten a question in the chat about our willingness to share some of the regional and local data that we collected with communities who are trying to figure out their behavioral health services. I don't know, Robin, if that's you as well, or if Gina wants to take that one.
I'm so sorry. I got
I'm happy
distracted
to
by
jump in, and then Robin can add to it.
Go ahead, Gina.
This is Gina. I will say that we are happy to help regions take the data and look at it a level down. Some of the data comes, I know the question was about health regions. Some of the data comes at different levels of region, right? Some are statewide, some are regional, some are county, some are more detailed than that. So we are happy to try to help people take that data a step down. I do think that our hope is, especially if you look at Appendix A, the data can be used to take a deeper dive into your region and to really look at all of the data points are done by region. And then there's a lot of data points in there that are done by county or below that. So there's a lot of information in there for counties and communities who are trying to look at behavioral health needs assessment. But we have actually already talked with a number of counties about sort of how does this data inform them, and we are happy to do that as people go along. We know that communities are really trying to address behavioral health, and it's only gotten worse with COVID.
Thanks, Gina. Okay, another question that we got in the chat is, when speaking of telehealth in rural and frontier communities, is there a discussion included about access to solid technologies and internet for the clients on their end to access the telehealth we might be offering? Camille, do you want to share some thoughts there?
Yeah, sure. So a few things. I think we are pretty aware that we have lots of opportunity to support patients and clients with telehealth services. And we know that in many cases, our clients that need that resource don't have the technology that they need. I think there are some instances in which many of our providers have been providing essentially tablets to their patients in some cases, and we know that's certainly not enough. On the broadband side, the Office of eHealth Innovation and the Office of Information Technology actually have a pretty robust request in the governor's budget this year to help support broadband access, which we think is really important. And then, of course, in our budget request, we did put in some additional requests for support around telehealth and technology support for providers. And so it is one of the things that we're thinking about. We know that not every community around the state has good broadband coverage. So.
Thanks, Camille. Okay, and I think we had a good discussion in the comments a little bit, sort of about forgiving student loans and about building workforce capacity. And Gina, I know you had answered some of the comments there, but do you want to talk a little bit more about workforce efforts or any next steps or recommendations there?
Sure, I'll say that I think that between the task force and the needs assessment, there's probably about 40 some recommendations specific to the workforce that I know OBH and the future BHA will be looking at for short-term, medium-term, and long-term impact. I think that some of the ideas that were brought up in the chat are really good ones around loan repayment. There are loan repayment programs for the rural and frontier regions. There are other loan repayment programs that people have looked at. There are also solutions being done by providers in parts of the
Gina,
state.
you're getting hard to hear. I'm sorry.
Frontier regions, there are providers building housing, trying to create opportunities for retain people or attract people to a region. I think that there's a lot that's out there, and I think there's a lot more that could be done to address this. I think we're going to have to expand the workforce to that non-licensed group, and know that, you know, through evidence that's very effective, often more effective in terms of engagement for some populations. So I think there's, you know, the task force and the needs next to each other. There's some overlap, there's some differences, but I think that's a great creative ideas about workforce for the future. And
Thanks, Gina.
and
And
thoughts there too.
we might have you just recap some of that in the chat too, just because it was a little hard to hear you at certain points. Sorry, darn internet, huh? So we will, we can type some of that out too. If someone from the HMA team can maybe add a few of those points, that'd be great. Okay.
Well, the loan repayment program, I don't know, Liz, if anybody from CDPHE is a participant, but the loan repayment program at CDPHE is may have information as well.
Okay. A couple more questions that have come in. How will some of the recommendations align with the hospital transformation program that HCPF is implementing statewide? The RAIs play a key role with some of the hospital transformation program measures pertaining to mental illness and substance use disorder. Camille, do you want to take that one?
Yeah, so we're quite aware of the hospital transformation program. And so we, as part of Senate Bill 222, are required to work with healthcare policy and financing around how to build out infrastructure. So I agree there is some nice opportunity for alignment if you consider the hospital transformation program and the work required in Senate Bill 222. So yeah, I think it's on our radar, but we don't have any concrete next steps that I can speak about related to that.
Okay, great. My copying and pasting went awry there. So hold on, everyone. I will catch up with the questions on that in just a second and putting them all in the chat. So another question that came in from the chat is, will there be funding from the state or OBH to help rural and frontier areas establish health partnerships or a local task force to address mental health and SUD? We've seen there is a lack of funding to help establish local task forces or alliances to address some of the complete needs in communities. Oftentimes providers and social service agencies don't have the resources needed to engage and address these issues collectively. Camille, do you want to start with that one too?
Yeah, sure. So we have actually not considered that idea, but I think it's a really interesting one. I think there's pretty strong set of recommendations in the behavioral health task force blueprint to ensure that there's good regional sort of coordination and responsibility to think about the set of services. So I think we can certainly put that on our radar and think about it as it pertains to some of our next steps in terms of our short and long-term work that we need to tackle.
Great, thank you, Camille. Another question that came in ahead of time is, when discussing needs in the needs assessment, are we referring to the needs for resources or more of an activities of daily living needs for patients? If someone on the HMA team would like to address that.
I'll try. I mean, I think in terms of need, I think it's, it was really about the behavioral health needs. So the acuity of mental health and substance use need, as well as how that need aligns with the services that are available. So then the service needs, right? So we really try to figure out to what extent is that matching up, right, at the community level across the state. But then in terms of sort of daily living, I mean, certainly a part of that continuum, which we hear a lot about, and we've heard a lot about in this SB, recent engagement, is that you can have, you need that support in daily living. So housing was a big one that was mentioned many times in order to really sustain a person's recovery. sustain their engagement in treatment. So those social determinants of health certainly was another component, certainly of need in terms of being able to sustain and engage in treatment. Does that answer the question?
I think so, unless anyone has anything to add. Okay. Thanks, Robin. We had also gotten some questions about EMS or emergency medical services. So reimbursement for EMS would be a key piece to better integrating EMS into the care of behavioral health patients. And what are some ways to secure funding for EMS reimbursement, or maybe just talking about integration more broadly? Camille?
Yeah, I think we actually have a number of examples of EMS doing and delivering services in our crisis system. We think that there's lots of really nice models out there, and a few of our counties have already implemented work around that area. And then recently, oh gosh, a month or so ago, I participated in a conference call with EMS and first responders, and there was lots of nice recommendations about how you might employ EMS providers to do withdrawal management in an individual's home. And so I think about Senate Bill 222 that describes opportunities for transportation and opportunities for diversion as fitting nicely in that set of recommendations. So certainly I think it's on my radar, and it's an interesting way for us to think about extending our workforce where we have workforce shortages.
Great, thanks. Thank you, Camille. Okay, another question that just came in. Will social determinants of health assessments be built into reporting in a manner that can demonstrate improvement? And I'm not sure who is best suited for that one, so.
Oh. Yeah, I can take that, Liz. So I think we are undergoing, I mentioned that we're doing a provider burden analysis. And so we know that provider burden is both at the individual provider that's delivering face-to-face services or telehealth services through the system to like large health systems that are contracted with multiple payers. And so we're thinking about all of those different pieces of the system and how it fits into a larger framework. And so we had previously, many of you know, started down the path of Compass, and we did have a set of metrics there that was related to activities of daily living and how an individual within the last 30 days have been able to do all their activities of daily living. And then there's also lots of nice examples around the state where I think patients are being asked about food insecurity and housing. And so it's certainly on our radar. And I think we'll start vetting this provider burden report that's halfway written and ready to go within the next week or two to get additional feedback. But I do think it'll be important that we consider social determinants of health as part of our set of core metrics that we're using to think about approaching behavioral health from a larger population health perspective. So that was a really long answer. So yes.
Always good to summarize at the end. Thanks, Camille. We're getting another question, and I don't know that we're actually best suited to answer this, but they're asking about, is there discussion around making the community paramedicine licensure easier to obtain for both the paramedic and the agency seeking licensure if there is a plan for them to fall into the workflow? Camille, do you want to take that one as well?
Yeah, so paramedic licensure is really in CDPHE's wheelhouse, but we're happy to connect folks, and it might be helpful to start doing some more work around partnerships with CDPHE and how we consider paramedicine programs in our delivery system.
Great, thank you. I think so if you all have other questions, now is your chance, because I think I'm down to maybe one question here, or if I've missed something, please feel free to put it back in the chat or something. Oh, wow, everyone really responded very quickly to that. We got 2 questions immediately, so thank you so much, everyone. So the first one that I'm seeing here is, has there been any discussion with co-occurring housing providers as of yet, and seeing what models are working in the community as of now to address SUD and mental health? Is that you again, Camille?
Yeah, so sorry, that it's co-occurring housing.
Yes, any discussion with co-occurring housing providers, and then looking at seeing what models are working in the community for addressing substance use disorder and mental health.
Yeah. So we actually have in our opiate funding resources to expand paying for rent for individuals that are in recovery. I still think that there is a lot of work that we can do around that. And so I think Chris Miller from our office, and then also Paul Barnett, are really running point on some of our housing work. So I think there's, again, it's an area in Senate Bill 222 that we're required to dig in a little bit more deeply in there. So I think that if individuals have recommendations or areas where we think that there's gaps in terms of that, we're happy to engage and partner with Division of Insurance on this, or Division of Housing, sorry. And we're open to taking recommendations. So if folks have ideas, please send us emails.
Thanks, Camille. And another question that just came in is, has Colorado considered allowing psychiatrists certified or licensed to prescribe in a different state to do so in working telehealth for patients here? And I know, Gina, if you're with us, I think you had some comments on that, or Camille, maybe you want to go first.
Yeah, I can go ahead and so it was actually one of the recommendations that came up in our COVID subcommittee of the Behavioral Health Task Force, was considering out-of-state providers where we have real workforce shortages, and the licensing of providers that are allowed to practice within Colorado is really part of what DORA oversees. But I think there's absolutely opportunities for us to think about how do you employ out-of-state psychiatrists. And I think there's a number of examples where many of our community mental health centers around the state are already doing that.
Gina, did you want to add something?
Sure, I just was going to add that we did make a number of recommendations on how to expand the workforce for psychiatry in the state, which I think is getting at one of the things that you're raising. In terms of psychiatric consultation, in terms of psychiatric hubs, a number of ideas about how to help train and expand that. I will say that we did hear in certain parts of the state, and some of the parts that the regions that have the highest need have the highest safety net populations, and also have some disparity in terms of emergency room utilization and some other indicators that are concerning, suicide, overdose, that they really do not like telehealth psychiatry. And the reasons behind that, when we tried to deep dive into that with stakeholders, was really around lack of cultural perspective. So if you're an out-of-state provider doing psychiatric telehealth here, that they, especially for them, this was in Alamosa and the San Luis Valley, when a provider doesn't have the cultural perspective of the environment around them, the challenges, the geography, the level of poverty, which was raised specifically for the San Luis Valley, there is no way for the individual to engage with them. So I think we have to think about telehealth more than just access or licensure, but really training, cultural competence, the ability to connect with individuals, and that they understand more about the region they're working in. And so I would just say that for providers doing telehealth, I know we've expanded rapidly in COVID. You know, we really do need to be attending to these other elements, because there's still regions of the state where the populations might have access to telehealth, but they're not going to use it because they don't see it as culturally responsive.
Thanks, Gina. And your audio sounds so much better. So I'm personally very excited about that and having you back. Okay, another question. I also don't know that we can really answer this one. It sounds maybe like a Dora question, but has Colorado considered allowing psychologists with the appropriate certifications to prescribe medications to help address the shortage? Does anyone have thoughts on that, or is that just a Dora question?
Yeah, I would say that's probably a Dora question. And I know there are some states that have explored that. I don't know, Gina, if you have anything else that came up in your national research.
It does come up a lot nationally, and there are significant pros and cons. So if it's a difficult decision for a state to make, there's some research that you really do raise risk for some of the chronic health, physical health pieces there. There's some data that shows it does help expand. So I think it's about the how, and if states are going to go down that road, really thoughtful attention to making sure that there aren't other risks or barriers that arise with it. So I can't say that there's really nationally a decision point at this point that one way or the other, just lots of pros and cons and potential risks.
Thanks, Gina. And you're all seeing the complexity of the behavioral health system here by us telling you that some of these questions are Dora questions and some are CDPHE questions and so on. So thanks for asking. The other question that I had on my list is just, are there any themes in the needs assessment that are related to just one stakeholder or one individual? If someone from the HMA team would like to take that.
So this is Gina. We have gotten this question a number of times. The answer is no. So if we heard something one time, that didn't come forward into the needs assessment. It had to be something that we heard across a stakeholder group. So say, for example, between individuals with lived experience, providers, and counties. We definitely tried to take the rule of thumb of 3 data points as the best way to make sure that you're getting clarity. So 3 data points across sectors, but also more than one stakeholder. So even if we had, for example, a RAE, an MSO, and a provider say the same thing, we looked for it more than one time. So we really tried not to bring themes forward that didn't fit a consistency level that we felt like allowed it to come forward.
Thanks, Gina. Well, I don't see any other questions. So if you have one, please put it in the chat quickly or in the Q&A. Otherwise, I was thinking maybe we have a couple minutes left if any of our panelists have closing remarks. Gina, I know you had something you wanted to say.
Yeah, thanks. I just wanted to say that, I have worked in the Colorado behavioral health system since 1997, which dates me a little bit. And I just think that this was really meaningful. And I want to say we've really named a lot of what's not working, but I want to say a couple thoughts about the fact that so much is changing in Colorado's behavioral health system right now. And I think there's a lot of good happening as well. We did try to highlight throughout the needs assessment some of the innovations, some of the really unique things that we see providers doing. And I just want to highlight that I think anyone who's interested in the behavioral health system in Colorado has good intention. There wasn't anybody we ran into who isn't doing their best, isn't trying to be creative and thoughtful and innovative and push past every barrier they can find in making the system better for individuals. We have a lot of community partners and non-traditional providers doing their best to fill gaps or connect people and really doing stellar work in terms of building bridges and connections, communities coming together, counties coming together. So I just want to say there's an enormous amount of positive things to highlight as well, even though we all focus on what's not working and where the challenges are. As Camille and Robert have highlighted, there's a lot of work ahead, but I don't want us to lose sight of that. And then my last comment is I just wanted to thank OBH and the team in particular and the leadership of CDHS just for the opportunity to work on this, for their creativity and also their real deep desire to get to good answers and to find solutions for the state. And it was really, I think, a good partnership. And then lastly, I just want to thank all the stakeholders, right? We had a lot of people who put time and energy into the needs assessment, and really we could not have done it without every single one of those individuals taking time out to talk with us or share ideas. So just a number of thank yous, but also I don't want to end on a negative.
Agreed, Gina. I think we're all hopefully energized by what we're hearing today and by what's to come. So I don't know, Camille or Robin or Shannon, anything to add?
I think that's beautifully stated, and couldn't agree more. I wonder if we couldn't put back up the link just in case people didn't get it, and I'm happy to share that again. But no, just thanks everybody for your time.
Yeah, and I just think I just want to say that I really appreciate everybody engaging on this and our community partners. I know that there's been a lot of asks from our community partners over the last several years, and in particular this last year, in trying to quickly pivot during COVID and participate in the behavioral health task force and participate in the needs assessment. And I would anticipate more engagement as we work through this next steps. So really appreciate your time. And then also, I just want to shout out to HMA for all your heavy lifting on this. You guys have been extremely patient with us as we asked you to pivot multiple times, and we've hit them with lots of additional last minute requests along the way, because everyone, as you know, wants lots of data right now. And so I really appreciate their work. They've been stellar to work with. So thanks everybody, and thanks for calling in and engaging. I know it was a couple of hours and we had a pretty significant turnout, so appreciate it. And yeah, if you need anything, please feel free to reach out, send an email. If you have ideas or something that we've not covered, please reach out to Liz or I, and we'll take it and see what we can get you back.
Yes, thanks so much, everybody. And again, this will be posted, this recording will be posted on our website. We'll post it on this behavioral health needs assessment page, the link you can see here. And then we'll include it in our newsletter and everything so that you can watch again and share with others. Thanks, everyone. Happy Friday.